Welcome to Joint Effort PAs, where two orthopedic surgery PAs get real about life in medicine. From tips and tricks to professional growth, work-life balance, and everything in between. We're here to share what we've learned and what we're still figuring out. Let's get into it. Am I the asshole or crazy or both?
Yes, today's episode. So this is us talking about circumstances that we have found ourselves in, whether that is, with our teammates that we work with or with patients. And you leave certain encounters and you say to yourself, either out loud or in your head, am I crazy or was I just the asshole?
Yeah.
Yeah.
And you're not sure if you're a little bit of both.
Yeah. And we're going to hash these out. We're going to get into it. All right. So, the certain situations, so things that I want to talk about, and again, I can talk about stuff that's happened literally this week, but patients, when they're requesting certain things, whether that's pain medication or work restrictions, when you suggest a treatment plan and the patient doesn't like that, patients who are dissatisfied with their care. And then we'll talk about administrative stuff like giving feedback to staff and also working with those that are not on the clinic side, whether that's front desk or the financial people in our work setting. All right, Hannah, taking a deep breath because I need it.
I know we had a lengthy decompression session prior to this. If only those could be recorded.
Yeah,
they could never be.
All right. So let's talk about some certain situations. So let's lump this into pain medication requests and treatment plan disagreements.
Okay.
Okay.
So I'm going to start with pain medication requests. And in PA school, I feel like they stress to us like pain medications are not a bad thing, right? Appropriately, and I fully agree with this, appropriately used, like they are a necessary part of your practice, especially working in a surgery practice. You are going to have to prescribe opiates at some point. But there is a fine line. So cue in the person who comes in and within the first 5 seconds says, I'm not looking for pain medication, but ...
Yes, that is not to be confused with the patient that comes in and says, listen, I have a high pain tolerance. Because when they say that, guess what? They don't.
Yeah.
They never do.
Yeah.
When someone says, I have a high pain tolerance, you say to yourself, this person has the exact opposite of a high pain tolerance.
Yeah. And if you are truly someone who has a high pain tolerance, I suggest you never verbalize that.
But people who don't.
Yeah.
They don't talk about it because they don't experience pain like that.
Yeah.
So my process, and I think Hannah, yours is very similar. When we see a patient for surgery, you indicate to them what the process looks like day of, and then what they're going to feel afterwards. And the patient will say to you like, hey, how much is this going to hurt? And the response to that is relative to the procedure they're having, which you do things and I do things that hurt less than other things, right?
Yeah.
So for instance, a trigger finger release done under local anesthesia is not the same as a reverse shoulder replacement, nor should it be.
Should it be.
But with that being said, you, the provider, have no idea what the patient is feeling. So you are making these assumptions based on your experience from what other patients tell you.
Yeah. Which, and I get, it's a very personal experience, right? Like one patient's experience is not going to be the same as others, but you see patterns.
Yes.
So, actually, our shoulder replacements are what I have found one of our least painful procedures. Like people typically require less pain medications for those. One of the most painful procedures we do is CMC arthroplasty. So when people ask me, how much is this going to hurt or how much pain am I going to be in afterwards? I tell them like, I will give you a relative answer, but it's very, very subjective.
Yeah. And it's running the averages. Like I will treat you for what I get feedback, the average length of pain medication needs to be used for. But you have patients who interpret pain management as pain eradication versus managing the pain. So I have had conversations with patients when, my process is preoperatively like, let's start from the bottom up. We're going to use multimodal pain control. So you're going to start with ibuprofen and Tylenol. If the pain exceeds that, you go to your first level pain med, which is going to be a lower level. If it exceeds that, then I'll give you a higher level. So you're asking them to basically gauge the amount of pain that they're in and then medicate appropriately. However, you have patients who don't want to feel pain and will reach for the heavier stuff to just not feel the pain. So that starts a situation of, well, I need more of that.
That's what works.
That's what works. So then, I'll pose to you, Hannah, you have the patient that comes in and says, hey, I finished my 3 days of Percocet. I need another refill.
Yeah.
Like, how do you deal with that? And not in a way that you're telling the patient what they should feel.
Yeah.
But also getting out of that room, not re-prescribing that.
Yeah. I mean, it really depends on where they are in their post-op course. I'm pretty liberal with those things, I feel like, but I will refill meds up until a certain point that I feel is appropriate afterwards before I really start having like those lengthy conversations. And once I feel like they've hit that threshold of like, you are towards the not even the middle portion of what people take anymore, but you're exceeding, that bell curve of most people are well off of it by this point, then we really have to start working on like titration and a different plan of weaning down. And I would say I'm pretty liberal about it though. Like I'm not.
So let's say,
how strict are you about it?
I like to do this is how it should go. I want to give you a strong pain med, which you're going to use for when you have bad pain, which I expect to be on days, let's say 3, 4, and 5. Then you're going to go down to the lower pain med. So patients generally freak out when they go to the lower pain med and they're not getting that same amount of pain control, which logically they shouldn't.
Yeah.
Right.
Yeah.
But you just kind of have to exist in that. So what I like to tell patients is, let's say we say bad pain is a 10 out of 10 or 11 or 12, whatever. Once you get to like a 7 or a 6, you're going to dip down to your next pain med and you're just going to coexist with the pain. So you're never going to get down in the first week or two after surgery to a 0. Like that's not my goal. My goal and your expectation should be we're going to manage your pain so you don't live on the narcotics. Now that is different for everyone. So, I will bring up the certain demographic of people that tend to experience more pain. But I want to, again, with the theme, am I crazy or am I the asshole, right? Let's say you have a patient that goes beyond what I would say my 2-week mark of refilling the heavy pain meds. And then I say, hey, listen, I'm going to refer you to pain management because I have a provider on staff that just does this. They just manage your pain and they will make sure that you're not having any side effects. Like that is what they do. I will manage your post-operative course, but I have a specialist who does the pain. Yeah. And then they look at you and they say, I don't need to see a pain management specialist. Don't send me there. And you're like, what am I?
Yeah.
I'm sorry, what?
There's a negative connotation with that.
Yeah. So. Hannah, are you calling me an addict?
Yeah, clearly.
And then you're kind of sitting there and you're like, but I'm not calling you anything. You're actually asking me for more narcotics. And I'm telling you my comfort level. To this. I'm telling you a solution to this. And I'm not saying no to you. I'm saying yes, but do it through this portal. But then they look at you like you're the asshole.
Yeah. And it's like you're still getting it through actually a provider in this office.
Yeah. Who does this safely and is recognized for doing that. Those visits never end with, they say, oh my God, thank you.
Yeah. This was a great idea.
But
that's what I wanted.
Yeah. So you're really in those visits trying to balance like being like understanding, like I understand you hurt. It's not that I'm saying you don't hurt. I understand you hurt, but I'm not going to do a good job refilling your pain medication. So, those are a little bit hard.
Yeah, but that's probably a better and more appropriate way to handle it because I think it can just get overwhelming, like the number of requests for that. And unfortunately, we have great staff that like handles a lot of that. And so, we kind of have like an algorithm of like, yes, refill up until this certain point. So I don't have to deal with a lot of that on the front end typically. But I think just setting the expectation levels and the expectation that, like you said, it's not pain exoneration.
Yeah.
Yeah.
I don't know.
Yeah.
Eradication.
Pain eradication. It's managing it.
So have you ever had a patient come back to you that has said, thank you so much for that referral to pain management?
No.
Okay. But in your head though, don't you want like, you are there to do what is best for the patient. Yeah. So my pain management referral for you or my refill for you is because I actually want you to do well. Yeah. And I don't think you will do well unless I manage your pain. But the way that should work, right, is that the patient should come back to you and be like, you know what? Thank you so much for that referral. I really needed that. I didn't recognize it in the moment, but I really needed that. Like, how many times has that happened to you?
That is there's many factors that go into that probably of why. But I think that is in the theme of, am I crazy or am I the asshole? I am the asshole to that person.
Yeah.
And I actually probably also am crazy to them. So I'm both.
Yeah.
Yeah.
Yeah. Well, because in a world that we ask patients for their feedback, the feedback from that visit sometimes is they didn't listen to me.
Mm-hmm.
They didn't believe me, which is, again, it's really, really hard to balance empathy, which I hear you, I understand you, but also drawing the hard line between what you're willing and not willing to do. Right.
Yeah. And also ultimately, like, what is best for them? Pain medication can be addictive, and taking it at these regular intervals to eradicate the pain and feel a zero all the time when you went through a procedure that by nature you're going to expect to have pain during, like that. If we were to never have those conversations with people and never try to wean down or manage things not the way they wanted it to be managed, then that would be a recipe for disaster on their part. So it's actually trying to do them a little bit of a favor. But
so let's talk about treatment plans that weren't necessarily indicated. So again, you sit in patient encounters and you come into that visit, like at least I will look at the patient, look at my last visit, and I kind of have the tone of what this visit should be. Mm-hmm. Like they're here for this. Like I had them come back in 4 weeks because we're going to talk about their return to work restrictions. So you go into that visit and you are like, okay, we're going to talk about where you are in your progress physically and what you should be able to do. Mm-hmm. So based on, your experience in seeing these patients when they come in for these visits, let's say you go in the room and you're treating someone who had a shoulder surgery and they have to work at a desk, right? They have to go back and work administrative work. So they, as far as their shoulder is concerned, need to place their arm on a table to be able to type. Yeah. Okay. They have to drive to get there, but they have to type. So you see that patient, let's say they're 8 weeks after a shoulder replacement, and you say, all right, I think you can go back to, light duty. That should be appropriate. You're not lifting, pushing, pulling, but you can work at a desk. And the patient says, no, I can't.
Yeah.
So how do you handle those situations?
I try really hard for, especially some of our bigger procedures, to set all of these expectations beforehand, knowing what the person's job is and what they're going to go back to. And we have that conversation on the front end. That way there's no surprises. Not saying that doesn't happen, though. I'm saying I try to. But yeah, those are a bit of uncomfortable conversations because I feel like the patient is always taking it as me pushing them to do more than they are comfortable doing. And then I get these little, these vibes and notes of I'm going to hurt myself again. I'm going to mess this up. You're setting me up for failure by telling me that I can do more than I feel comfortable doing.
But I also feel like that's kind of a threat.
Yeah, it is. It feels threatening to me. It feels threatening. I'm going to undo whatever.
Yeah, I'm going to undo what you did because you personally are placing me in a very volatile situation.
Yeah.
Whereas, you can't control a work environment, but for a lot of these patients, we don't send them back to work to put them at risk because starting over and starting this journey all over again, that's really, really hard for both parties.
Nobody wants to do that.
Nobody wants to do that. But there is an undertone of a personal attack on the patient when you put the hammer down and you say, hey, I think you can go back to desk work.
Yeah.
So,
but here's the thing too. I don't know if this is your experience. I feel like I don't get a lot of the negative energy about these things. Unfortunately, it ends up coming back on the staff a lot of the time because I have these full-on conversations with people and they understand all right, you can go back with XYZ restrictions and, we're not going to have you doing this, or this, but it sounds like based on the job description you're giving me that should be fine. And then they're like, oh, okay, cool. They go home. And then days later, we get a call back, the total opposite. Conversation never happened.
I think they yes you in the room. So moving off of the work thing, again, this week, because this happens on the daily or on the weekly, I had a patient who came in who I'm seeing her for her post-operative shoulder. She's actually doing great. But she says during that visit, right? And this is from, I digress a little bit, but from a billing standpoint, you see someone for surgery for 90 days, they're in this, what we call post-op global period. So all their visits are covered under that surgery fee. So she says, hey, do you think you can order an MRI scan for my other shoulder and my knee? And I was like I could, but physically, yes, I can. I'm able to do that. But in this post-operative visit right now, I'm going to now interview you and ask you about your shoulder, interview you and ask you about your knee. And then you have already told me what you want from the visit. So if I go through the correct motions of working it up and examining you and I don't feel you need an MRI, I'm the asshole.
Yeah. Yeah.
So I'm exercising my clinical judgment, but you have already told me what you want. So
if we don't
in the world of patient reviews, like if I just go ahead and order that risk benefit, am I risking anything? No. Yeah. Is it what I learned to do and what is appropriate? No. But will that make that patient satisfied and at least continue their care? Yes. Yeah. So what do you do in those situations? Because I know they happen.
Yeah, they happen all the time. It's like riding this fine line of customer service versus like what
clinical judgment.
Clinically what you should do to be a good PA. And I'll try to always fall back on like just be a good provider, be a good PA, nurse practitioner, physician, like do the right thing that you think should be done, because you'll never yes, you may have frustrating, uncomfortable conversations because of that. But you'll never look back on the day and be like, oh, I did the wrong thing just because it was easy and uncomfortable to have the conversation. But handling those is tricky. I feel like, more often I get into this situation with post-op visits or even a regular visit where somebody comes in for like 10 complaints and wants them all worked up. And I mean, I sound initially like the asshole when I'm like, I'm not going to look at your shoulder and your knee and your hip and this finger and your other wrist because I can't do a good job at all of those things in the allotted time.
But I also feel like if you take that in any other facet of life, let's say I bring in my car to get an oil change, I get an appointment, and at the oil change, I'm like, hey, can you also change my tires, rotate my tires, do an inspection. And also you told me it's going to be half an hour, so I'll be back to get my car then. It's an unrealistic expectation on the services provided. But at the same time, if they told me no, I kind of would leave a little bit upset because I had expectation of but I'm here. So
I might as well get it all done kind of thing.
Yeah. But I think it's very, very difficult to get out of these situations being the non-asshole.
Yeah. Yeah.
So did I see the patient for their left shoulder and their left knee and order those MRI scans? 100%. I totally did.
Most of the time in a situation like that, that's not harmful to end in that, right? It's just it's a path of least resistance.
Yeah. Good barometer is am I doing anything negative for this patient? No. Am I screwing myself for the whole day by making myself too far behind?
Yeah.
Not terribly, but you end up paying for that for the sake of the patient satisfaction.
Right. For that patient satisfaction. And then the next one, you're late in their room, they're and they're probably a very nice person who had one simple thing. And I'm like, oh my goodness, now I'm way behind because of that. And what about so I know we talked a lot about the pain meds and work notes for surgical things, non-surgical things. I feel personally that's another thing that I struggle with, not being the asshole with, is not writing people out of work for things that we haven't even operated on.
Yeah. And I even take that to gym class for the kids that we see, they'll say they came in for, let's say, patellar tendonitis, something that's not limiting.
Yeah.
And hey, can she get a note for an elevator pass and to not do the stairs at school? And I was kind of no, I think you can navigate stairs fine. Oh, but she'll be late for class.
But it hurts.
I'm no, I understand it hurts, but generally we don't do those accommodations unless you have something surgical. And then the parent looks at you but she comes home and tells me her knee hurts, and then I resist the desire to say, listen, I get out of bed every day and my knee hurts.
I know.
You know what I mean? It's very hard.
Right now.
It's very hard to try to not normalize that, but also validate their feelings, and then they feel like they're heard and then taken care of. So
but you're also doing a disservice to people by overdoing things, right? Like
you're excusing, or you're validating their excuses, and
emotionally and physically, because you also like. It is also our job to get people like, yes, I understand this hurts, and this condition that you're experiencing can cause pain flare-ups, and XYZ activity might be uncomfortable, but that is not a sign that this needs to be done about it, that you shouldn't walk up and down stairs for the rest of your life because of it. So or that you should never work again. Like when people come in and they have carpal tunnel and they're like, I need a work note to never type again. And I'm like, no, that's not true.
Or the teenage kid with the patellar tendonitis, the parent then says, hey, do you think you can write me a handicap placard so that I can park closer so my kid doesn't have to walk very far? And I'm just like, no,
I'm creating a monster.
I'm creating a monster. Yeah. I mean, I don't like to condone that. But again, you leave there and you're like, okay, if I'm put my foot down too hard, I'm an asshole because I'm not listening to this child who's asking me for help, if you really simplify it. Yeah. But, I leave those visits and I look around like, am I crazy? Am I missing something? Like, I don't know.
No, but I go back to like, I think taking the other approach, you would also be doing a disservice to people.
Yeah.
Okay, let's go into being the asshole in workplace dynamics.
Yes. This is, again, a little near and dear to my heart because I've had a couple situations just this past week that, I feel like this happens again on the daily. So with patients, again, there's a little bit of a power dynamic where you are in control of the visit, in dictating. They're seeking you out for your advice and for your care. At the end of the day, you are collaborating with a treatment plan, like you are suggesting what to do and the patient is agreeing with that. So you leave those visits, do you have any questions? You guys are relatively on the same page, except literally all the situations we just talked about. But
except those
for the most part on the same page. So in let's use provider and medical assistant, or provider and front desk, or manager, meaning like a provider manager and those that work underneath them, where you have a situation where you're trying to fix a problem and you guys are not seeing eye to eye. I'm being a little vague.
Yeah.
But let's get into it.
Yeah. I think we have two very different personalities in this. I work hard on this issue with my personality, but I'm very passive. And so I would rather in the moment just like cower in the corner and accept not liking the way a situation is going, just so that everybody else is happy and comfortable, and then like curse about it.
Yeah. So that's what we call passive aggressive.
Yeah. No, that is what I am.
So I had a medical assistant once upon a time that came with a lot of credentials. He did, orthopedics elsewhere. He actually was an athletic trainer. So there was more things they can do as far as being a physician extender, as opposed to just doing kind of chart stuff. So this medical assistant that we hired had a couple admin days. So admin days are when, myself is in the OR and I don't have a clinic, right? So this is doing, listening to patient calls, answering them back, doing paperwork, looking at the schedule for the week and making any changes. This person told me, okay, and this was after they were hired, that at 5:00 they are not available. And I was like, okay, I mean, those are boundaries. And again, we can have a whole separate conversation about healthy boundaries. But as our guest last week had said, if you have one thing, whatever that thing is, we as providers need to be able to fire and release. Like if I tell Hannah, hey, I need you to see, I sent this patient to the ER for a blood clot. Like I need you to follow up on that.
Yeah. If
the patient didn't get there till 4:57, I expect you to go home and refresh your computer and tell me if they were seen or not. Yeah. So this medical assistant said, I'm sorry, I can't do that for you. Like after 5:00, that's it for me. So the dynamic right there is, okay, you have just told me that you're not going to go the extra mile. And again, I'm not asking for it every day, but the workload dynamic, you have now told me it is all on you. Like I am not going to help you with this. I hear you that you need my help, but I will not do that for you. Yeah. So I ended up having a conversation with this medical assistant. And I said, listen, like in order for this to work well, if you have a thing that exists beyond 5 o'clock, I respect the fact that you told me you're not going to do that, but I need you to sign out to someone else.
Yeah.
And he looked at me like I was crazy. And I was like,
you're giving a solution to...
I'm giving you a solution and respecting your boundaries.
Yeah.
And it ended up, he ended up working somewhere else and left the position, not voluntarily, but whatever. And his feedback was that I was too demanding. So again, am I crazy? Am I an asshole? Because I feel like I addressed the issue, which was not, brought to light when they were hired, but whatever. I addressed the issue, offered a solution, yet I came out the asshole.
Yeah. I think this goes back to like, know what you're getting into kind of thing. You know, like this, did you think it was the job for you?
Right. Right.
If you're not willing to take responsibility for things that happen after 5 o'clock, because this is not an 8 to 5 job. And I think people have to understand that going in.
Yeah. But again, like boundaries are good. I will accept boundaries, but like, I think it's not appropriate to think that you are not going to have these conversations when situations arise. Like just because I said to you, these are my boundaries, it doesn't mean we're never going to talk about it.
Yeah.
That's just not something that's off the table. So do you think, and again, you alluded to this a little bit ago, do you think your feedback style is more direct or gentle, or can you sway both ways?
It's just gentle. I know. And I'm like, not team. Well, I'm not a parent. So let me preface by saying that I have no children, just my dog. But like, if somebody were to ask me if I was like team gentle parenting, I'd be like, no, that's silly.
Right.
But I'm definitely gentle in it. But I recognize that it is not not efficient at all.
So we have in the past here had front desk staff, and they're the face, right? So patients check in, and if the provider's running late, the front desk unfortunately has to hear that. The front desk has to hear the anger of the patient if the provider's running late. Like the front desk is there literally to clock in, clock out. Like they don't have that same investment in the flow of the day that the
like
providers do.
It does end at 5. Like
right.
There's no responsibility after.
Right. So we had a situation recently, and again, this is probably true of all practices. The patient comes in to be seen. They log into their chart and they say, oh, hey, you have a balance. And the patient says, well, I'm not paying that. Okay. Well, our policy says you have to pay that in order to be seen. And the patient says, I'm not paying that. Mm-hmm. So front desk person gets up, comes back to clinic and says to me, hey, this patient's here to see you. And I told them the policy of paying the balance and they don't want to pay it. What would you like me to do? And again, this front desk person, it's not personal, but this particular person, super sensitive. And even just communicating that to me, I could hear shaky voice. So I was like, oh God.
No.
So in that situation, which I explained to the person, I thought was gentle, but Hannah, guess what? It wasn't. Okay. So I said to the person, so you left where you were checking the patient. You said to the patient, hey, let me check with the provider. So now when you return and you tell them I said no, now it's a me rule. So now you have just pinned me against the patient versus the company policy. So I looked at the front desk person. I said, so understand you just put me in this situation. So now I am forced to see the patient. And so the front desk person was like, well, I mean, you don't have to. And I can tell them. I said, no. You could have told them, but you didn't. You actually now put it in my hands. Yeah, so now I'm forced to see the patient. And the front desk was like, well, but that's not our policy. And I was like, I mean, again, with all due respect, like it isn't. And I don't even want to have this conversation, but you're forcing me to.
Yeah.
So she left that encounter. She literally was like, I'm sorry. And I was kind of like, don't apologize. So now I'm the asshole. Why did I feel bad? Yeah. Why did I feel bad about that? Because you didn't necessarily do your job. Like I still think being direct is the best.
It is.
But again, I don't know that you can get out of these situations and ever not be the asshole.
Somebody has to.
Somebody has to be the asshole.
Yeah, this is my take on all of this. Somebody has to be the asshole, and it is going to just be me. We were having this conversation beforehand too about the balances, and had a patient a couple weeks ago who was told that they were supposed to pay a certain amount for their procedure. It was due the day of before we did the procedure. That is our policy. Same thing. They come up, oh, the patient can't pay XYZ amount. I'm like, well, they were told, and that is our policy, correct? Correct. Okay, well, now there's a circle of 5 of us just standing around staring at each other like, what's going to happen? I'm like, well, I'm just going to go talk to them and tell them that myself then. And now I will allow myself to be the asshole.
Yes.
So, sometimes being the asshole is just taking one for the team.
All right. Now, we can go all day, but we won't.
No.
So I'm going to throw out some very specific mini situations, and I'm not going to necessarily tell you. Well, I will tell you. I'll tell you how they landed, but I want you to tell me if I was crazy or if I was the asshole. Are you ready?
Yep.
Okay. I saw a patient in surgery. The patient was having their left shoulder operated on and had a left wedding ring that they hadn't taken off in 20 years. Looking at the patient, the ring was 5 sizes too small, right? It never was going to come off. In order to have the surgery, the patient had to have the ring removed. So the nurses who checked them in tried, they lubricate it, they use dental floss, whatever, can't get it off. So then they say to me, what do you want me to do? So I go talk to the patient and I say, hey, so we need to take the ring off to proceed with the surgery. If we don't, your finger will swell and then you may lose your finger. Like that's reality. So the patient says, like, I don't want to lose the ring, but I also want to have the surgery. So then I say, there's 2 choices here. We reschedule or we cut off the ring. You let me know what you want to do. Long story short, she waits hours and then the nurses tell me she's ready. So I go over there, I look at the patient who's not medicated. I look at her husband. I say, all right, we're going to cut this ring off and then we'll do the surgery. Is everybody on board? Yes, we are. Take a ring cutter, cut the ring off, do the lady's surgery. And after the surgery, the nurse says to me, hey, the husband wants to talk to you. He's really upset you cut the ring off. So I told the nurse, absolutely not. Like, I'm not talking to the patient. So I asked the nurse to very clearly diffuse the situation because I don't want to stop my clinical work to talk about why I cut the ring off that was consented to be cut off. All right. Yeah. Am I crazy or was I an asshole for putting the nurse in that situation?
No, that's a boundary. That is that's in my mind, one of those things that is something that can be handled by someone else. When people ask me to do things and clearly I have 10 other things that I'm doing right now, and this is something that involves maybe an uncomfortable conversation on your part and you just don't want to have it.
Yeah.
And you want me to do it for you and now take away from all the other bajillion things that I'm doing.
So again, I'm biased. Hannah, you are correct. I was not the asshole. I was delegating. Asshole. But guess what? That nurse was very upset with me afterwards. So how did that end up?
Not good for you.
I was the asshole.
Yeah,
okay,
you're the asshole. But again, you always will be. All right, so see a patient. I'll make this more relevant to your world. So you see this patient, impingement signs, treat him for their shoulder. You give them an injection. They get a little bit better with the injection. You see them back for a follow-up visit. You have them do therapy. They do therapy for 6 weeks, 8 weeks, whatever. Little bit better, still not great. Come back, you order an MRI. They have a partial cuff tear. And I actually don't know your algorithm of what you might do next, but say they end up seeing your provider or your supervising provider next, and they give them the option, now that they have failed therapy and the injections and whatever else you may have done first, for surgery. And then they, in their minds, think back to you, I needed surgery.
Yes,
why did this PA make me do therapy for 2 months and have me do all of these things that didn't help, and I've been suffering, and now, surgery, I needed surgery all along, and they never recommended that.
So, okay, the reality, and again, this is not an opinion, this is fact. The reality is they came to you and you are a trusted provider. If you see someone who you do not believe will require surgery, and again, that's not will eventually need, but requires it. There's certain things that will not heal and require surgery. And still some people elect to not have surgery. There's some things that do have the potential to heal And if you want to give them, quote, the benefit of the doubt, you send them to therapy, do the injection. So I'm siding with you. I think you did that patient justice by allowing them the opportunity to heal. They happen to be seen chronologically at the time that they were by the provider who made the decision that they needed surgery. But in this situation, and again, my parents are of that generation where they would also think you were an asshole.
Yeah. That is our job, though. In the algorithmic workup of patients, we're the ones who are failing the non-operative stuff for the things that are appropriate, right? Obviously, I'm not doing this with like
displaced
a person
fracture.
with a distal radius fracture. I'm like, try therapy for a little bit first, right? But like in an appropriate setting, yes, that is my job, is to be the gatekeeper of these things.
Yes.
And then once it is to a point where you've failed everything else and it is surgical, well, yeah, now you are gonna end up at that option. So.
Yeah, that's a terrible situation to be in, because guess who's going to do their postoperative care?
Me.
You.
Like, I needed this the whole time.
But again, it throws off that balance.
Yeah.
God, all right. I'm like a little bit more pissed off than when we started. I'm not sure if that was the point of this.
No, it was. Yeah.
Okay, so some takeaways here, and why are we talking about this? So I think it's an art to balance being direct and assertive if you know that it benefits the patient or the work environment. Okay. So question for the audience and for you is, sometimes being the asshole actually just being the professional?
Yeah. You do have to be a little bit of an asshole, especially in this setting. I mean, in order to accomplish things, you are going to have to be the asshole sometimes.
Yes.
That's like a fine line that I have to increase the amount of asshole-ishness that I am.
Yes.
Like, that's something I am actively working on, is being more of an asshole.
Substitute the word assertive. I think assertive, direct, and professional are all substitutes for what you are considering asshole-ish. But I agree with you. I think being professional and being direct leaves little room for questioning, right?
Yeah.
Question 2. Do we have to ask ourselves, are we the crazy person because the system is sometimes crazy, aka work restrictions, pain medication requests? Like, are we crazy, or is the system crazy?
No, the system is crazy.
The system's crazy.
I mean, is that a coping mechanism for me to think, just because I don't want to be the crazy one? But
I don't know.
No,
like,
the system is crazy.
I don't know.
Insurance companies, crazy.
Yeah.
Like expectations from, and this all trickles down from insurance companies ultimately, but like expectations of volume and patient load and like how much has to be done in one single day in a private practice. That is crazy.
It's crazy.
It's insane.
In order to be successful in outpatient medicine, your volume has to be excessive.
Yeah.
It has to be. And that is dictated by society and insurance and patient expectations. And we fall in line. So again, are we crazy for falling in line? Yes. Is the system crazy for putting these unrealistic expectations? Yes.
Yeah. But we're just over here trying our best.
Yeah.
Gosh.
But again, I think at the end of the day, if you are asking yourself this question, so any provider, NP, PA, MD, DO, am I an asshole or am I crazy? I think it's because we actually care. Like, I want there to be a difference. I don't want to be crazy or an asshole. I kind of want to do what's right. So,
I want people to look back and be like, well, she did that because the amount of firmness that I needed. Yeah, in that
like
situation.
she appropriately denied my oxycodone because she does care about me.
Yeah, and then you want them to write you a letter 2 years later and be like, I'm not addicted to Percocet because of you.
Yeah, and that you want them to say it was because of you that I changed my path and I was successful, and that's how it should go. That's how the story should go.
Yeah, I hope that happens for you one day.
I hope that happens for you one day. Great.
Okay, awesome. All right. Well, in the next coming weeks, we have a plethora of topics. We want to discuss millennials in medicine. We are hoping to get some other guests on here soon. So yeah.
Until then. Thanks for tuning in to Joint Effort PAs. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with a fellow PA or med-minded friend. You can also follow us on Instagram at Joint Effort PAs for updates and extra content. See you next time.